All right, so part 2 of etiologic factors, we're talking about systemic factors that can cause issues with periodontal disease. So again, chapter 15. So systemic risk factors. Basically, this means it's a condition or disease that affects the individual's chances of getting periodontal disease. Therefore, you need to modify the host response to make sure they're not having a higher chance to perio. So these are the types of risk factors that are systemic that can cause issues with periodontal disease. And remember, systemic factors can modify the immune system or the bacteria. So that's how systemic factors play and role with periodontal disease. So diabetes, leukemia, HIV, osteoporosis, medications, hormonal variations, genetic influence, Down syndrome, tobacco, and inadequate nutrition. All of these things are risk factors involved systemically. So diabetes mellitus, the number one big gold standard risk factor for perio and link is diabetes. If you have a patient with diabetes, you know they're going to be most likely having periodontal disease as well. What is diabetes? Well, diabetes is when the body cannot produce or use insulin correctly. So you have 3 types. Type 1, which means the pancreas is not creating insulin on its own, so there's damage to it. So these type of people are insulin dependent. And then you have type 2, which is the most common type. Most people in America are type 2. And this is when the body does not make enough insulin. So type 2, it's not that your pancreas isn't making insulin, it's that you're eating so much sugar that your body can't make enough insulin to keep up with all the sugar in your blood. And then you have gestational diabetes, and this is just a pregnancy-related diabetes, it's temporary. And then you have type 3. Type 3 is diabetes that contributes to cognitive decline and Alzheimer's. And that's kind of a new one. We haven't really heard of that one. All right. Little things to know about diabetes. Individuals that have well-controlled diabetes don't have any more risk for perio than people without diabetes. So if you have diabetes and it's controlled, you are not more at risk than someone who doesn't have diabetes. Only when the diabetes is functioning an issue is when it's going to start being an issue with periodontal disease. So individuals with undiagnosed or uncontrolled diabetes have the higher link to perio. So it's not necessarily diabetes that's the problem, it's uncontrolled diabetes. So here's a picture of uncontrolled diabetes, what it can show up in the mouth. You can see localized tissue swelling. On this picture, we're looking at the lateral incisor along the gingival margin, and there's a big circle, a big oval shape, redness and swelling going on. This is a hallmark sign of uncontrolled diabetes when you see vascular lesions at the gingival margin. And here, right here, is a vascular lesion. See? So, children and kids with diabetes, what about them? So kids with diabetes also have a risk for periodontal disease. Normally when you think of perio, you think of older adults, upper 30s, mid 40s, but kids and teens can also have perio, especially if they have a link to diabetes. So this is why it's important that children with diabetes should be screened for perio. And if they do have perio, they need to receive early intervention and prevention to help save their tissues and bone loss and stuff like that. Bone structure, sorry. All right. Oral health complications in poorly controlled diabetes. Remember, diabetes isn't the problem, it's uncontrolled diabetes. So, what happens as a complication in the mouth due to this? For diabetes, you could have poor saliva flow or xerostomia, burning mouth or tongue, Candida albicans, increased chance, increased for perio, like we talked about, increased for rapid destruction of periodontium, which again is a sign in periodontal disease, reduced PMN function. So that is your neutrophils, polymorphonucleosides. These are important in periodontal disease in the prevention of perio because they eat up and phagocyze the bacteria in your mouth. If you have diabetes and a risk factor for that is reduced PMN function, then you're going to have a higher chance of having less phagocytosis in your mouth and more bacteria hanging around. Increased glucose in gingival corricular fluid. So if you have really, really high blood sugar, you're going to have sugar in your gingival corricular fluid, or GCF. And increased AGEs, or accumulated glycation end products. AGEs impair healthy tissue turnover of collagen. So, in order to have lots of turnover of collagen, which again makes our body elastic and strong and tight, and it's important to have collagen in your tissues because in your tissues you'll be tight, you need to have AGEs. I'm sorry, you don't need to have AGEs. Sorry, let's review this again. AGEs impair healthy turnover of collagen. So, if you have a lot of accumulated glycation end products, you're going to not have as much tightness in your tissues. So diabetes increases AGEs. Alright, so that was diabetes. Now let's go over leukemia. Leukemia is a blood cell dyscrasia or disorder. So remember, leukemia is when you have an issue with the white blood cells. So, leukemia-associated gingivitis. This is signs in the gingiva that are swollen, glazed, or spongy. You can also have really red and deep purple colored gingiva, and then gingival enlargement. So let's look at a picture of that. Reddish inflammation going on. I think we said it was swollen, glazed, and spongy. This one definitely looks glazed. So that was leukemia, okay? Human immunodeficiency virus, HIV. So, in the gingiva, manifestations of HIV were used to be known as HIV-associated gingivitis. That's no longer the term. Now, it's linear gingival arrhythmia is the new name for gingivitis associated with HIV. So, linear gingival arrhythmia is 2 to 3 millimeter marginal band of intense redness around your free gingiva. It literally is exactly what the name says. Linear gingival arrhythmia. Linear redness in your gums. Linear redness in your gums. So here on the picture you can see that red wavy line going up and down around the teeth, just that band of redness and swollenness. Linear gingival arrhythmia. Then you can have hormonal variations. So basically levels of sex hormones vary throughout your life, such as puberty, pregnancy, when you're lactating, or when you have menopause. And these hormones are to bacteria as steroids are to professional athletes. So basically, hormones make bacteria bigger, badder, and stronger. So puberty is an increase in hormones and causes increased blood circulation to gingival tissues. So you're having more blood flow go through your tissues. This can cause, higher chances of gingivitis. And also, puberty has increased levels of blood, can cause sensitivity to local irritants such as biofilm. So pubertal gingivitis occurs equally in males and females. Pregnancy. Pregnancy is an exaggerated response to small amounts of plaque. So when you're pregnant, your hormones are really crazy and wild, and they become hypersensitive to the smallest little bit of plaque. It usually occurs in patients who have gingivitis before becoming pregnant. So basically, if your oral hygiene was good before being pregnant, and you continue to practice good oral hygiene, there usually isn't a problem. You usually don't see these hypersensitive reactions to biofilm. So the bacteria associated with pregnancy are Prevotella intermedia and Campylobacter rectus. So how can we remember those bacteria? Well, let's think of it this way. Prevotella, when I see that word, I kind of think of the spaghetti sauce Prego, because it has very similar letters, Prevotella, Prego, and you can think that's associated with pregnancy. And then Campylobacter rectus, well, what could we say about that? I'm not sure, but we'll just have to associate that with pregnancy. Campylobacter. You can think I named my kid Philo, or you can think I got pregnant at summer camp. You know, those things might work. Also, it's important to think about a lesion that can occur in pregnant women, and it's called a pyogenic granuloma. And basically that is just a red swollen lesion on the gingiva that is due to really swollen gums and bacteria in the area due to hormones. So, elevated progesterone enhances capillary permeability, and progesterone and estrogen also suppress the immune system. So if you have a lot of estrogen and progesterone going on, you have a less strong immune system, which makes sense because when you're pregnant, those hormones are going crazy. And when you're pregnant, you can get sick easier, you can have issues with your immune system, and so that makes sense. It suppresses the immune system. Here's a picture of pregnancy gingivitis. It's glossy, generalized bulbous. You have to be careful because, you know, you have a lot of different types of gingivitis. You can have pubertal gingivitis, leukemia or HIV-associated gingivitis, and then that linear arrhythmia, gingival arrhythmia line. So you have to be careful when you're looking at the gingiva because it can all look the same. Menopause and postmenopause, how do those affect your oral health? Well, decreased levels of circulating hormones in menopausal and postmenopausal women result in oral changes. Dry mouth, burning sensation, altered taste, and bone loss may be exacerbated because, again, a lot of women have osteoporosis when they're older and they've hit menopause, and this can happen in your mouth as well. All right, osteoporosis. Osteoporosis is a weakening of bone structure, usually in older women after menopause who do not do weight bearing or are bedridden or stuff like that. They're not using their body as much. So we talked about osteoporosis as a loss of bone mineral. It can be seen in older women, bedridden individuals, sedentary individuals. The treatment of osteoporosis is almost as bad as the disease. Why? Well, for osteoporosis, you have to take certain medication that over a long period of time can damage the bone. So when the steroids, you usually take steroids, when the steroids shut off the osteoclasts, the body stops rebuilding by stopping making osteoblasts. Therefore, the bones ends up fossilized, and it's called osteonecrosis. Excuse me. Osteoporosis affects more than 20 million people. It may be linked to skeletal osteoporosis and alveolar bone loss. Osteoporosis does not initiate perio. It can just exacerbate perio. Okay. And now we'll talk about genetic influence. So this is no longer systemic issues. This is genetic issues. So let's see here. What are rare genetic influences that can lead to unusual forms of perio? Neutropenias, which is diminishing of neutrophils, which again makes sense. If you don't have a lot of neutrophils, you can't fight off the bacteria or phagocytize it. So neutropenia would make sense. Then you have Chidak-Higashi syndrome. This is a decrease in phagocytosis, so very similar to neutropenias. And then Papillon-Lefèvre syndrome. That is a chromosome defect that leads to loss of all deciduous teeth by age 4. and then you grow in your permanent teeth fast and you lose those teeth too. It's basically a gene mutation. So that's Papillon-Lever. So many of these rare disorders are accompanied by PMN malfunction, or malfunction of neutrophils, which again makes these patients more susceptible to infections. So specifically, genetic issues could be Down syndrome. It's one of the most common birth defects. It's frequently treated in general and periodontal offices. You usually will have a Down syndrome patient. So Down syndrome, normally a person has 46 chromosomes, and a patient with Down syndrome would have 3 copies of the 21st chromosome. So that's why Down syndrome is also called trisomy 21. Basically, Down syndrome, people with Down syndrome, live longer today than they did before, and they have periodontitis and limited function. So patients with Down syndrome will have more tongue thrust issues, low cognitive understanding, so that can affect their self-care at home, and this gives them a multifactorial risk as a patient with Downs. So medical problems that develop from in patients with Down syndrome: you can have increased risk for heart defects, infections, respiratory problems, GI. You can have childhood leukemia, PMN function also. So we talked about, again, impaired PMN function affects chemotaxis and phagocytosis, which means there's a higher bacteria in the mouth. Here's a picture of it. We can see lots of multifactorial effects in a patient with Down syndrome. You can see the facial-everted teeth, malocclusion, lack of self-care at home, that kind of stuff. You can also take genetic tests to see if you are prone to be more susceptible to perio. And there's that. Some of the tests you can take are oral DNA labs, myoperio ID tests, which tests for interleukin 1 and interleukin 6. So if you take that test and you have the interleukin 1 genotype, you are at risk for periodontitis. And that discusses more of it. And then lastly, systemic medications. So if you take some medications, they can cause systemic effects that can also affect your mouth. For someone who has systemic medication side effects, you want to look for, you can have agranulocytosis, which is a side effect where the medication kills off granules in the immune response. Also, you can have neutropenia, which we talked about is a diminishment in neutrophils. And most important, here are some of the medications that can affect the periodontium. Anti-seizure or anticonvulsants, they cause gingival overgrowth. Anti-anxiety, they can decrease biofilm formation. Antihypertensive, increase gingival inflammation. Calcium channel blockers, gingival overgrowth. Immunosuppressive, gingival overgrowth. So those are the ones that you want to watch out for that can affect the periodontium. So that is part 2 of etiological, local, and systemic factors.